Welcome back to the deep dive. If you're working in PEDS, neurologic disorders are, well, they're a really big deal. So today we're really jumping into the core concepts around intracranial regulation in kids.
Yeah, it's absolutely a high-stakes area. Intracranial regulation, I mean, it sounds complex, but it's essentially about balance, right? Keeping everything inside the skull, the brain tissue, the CSF, the blood, in dynamic equilibrium. And when that balance gets thrown off in a child, well, the outcomes can be really devastating and, often permanent.
Absolutely. So our goal today is to pull out the really essential stuff from your sources.
No.
We want to move pretty efficiently, from the basic anatomy right through to the critical interventions. We'll hit on structural issues, seizures, infections, trauma, and those chronic conditions too.
Exactly. But, before we even get to the specific conditions, we have to talk about the foundation. Like, why are kids, especially infants, so much more vulnerable than adults when it comes to neuro stuff?
Okay, yeah, let's unpack that. What makes children inherently higher risk for, say, head trauma or a brain infection?
Well, it literally starts before birth. The brain, the spinal cord, the whole CNS, it forms from the neural tube really early, like the first 3 to 4 weeks of pregnancy.
Wow, that's incredibly early.
It is. And during that tiny window, the system is just extremely susceptible to, infections, trauma, any harmful substances, even poor nutrition. The impact can be huge.
And that vulnerability doesn't stop at birth, does it?
Mhm.
The physical structure is different too. Those cranial bones, they're not fused yet.
Right. That offers a bit of flexibility, which can be good sometimes, but it also means the skull is easier to fracture.
And what about the brain itself?
It's much more vascular, lots more blood vessels. So if there's an injury, the risk of a serious bleed, hemorrhage, is way higher.
Hmm.
This is a huge issue for preemies, Their capillaries, especially around the ventricles, are incredibly fragile. Intraventricular hemorrhage is a major concern there.
Okay, and then there's the sheer proportions, the head size on an infant.
It's massive compared to their body, like a quarter of their total height. In adults, it's more like 1/8.
So you combine that heavy head with neck muscles that are still pretty weak.
Exactly. And suddenly, even a minor fall poses a much bigger risk for that sort of whiplash, acceleration, deceleration type injury inside the skull.
Okay, that makes sense. And developmentally, there's also the myelinization process, right?
Yes, absolutely crucial. Myelin is that fatty sheath that insulates nerve fibers, helps signals travel fast, it's not complete at birth, and it develops in a predictable pattern. Cephalocaudal, head to toe.
Which totally explains the motor skill progression we see, right? Babies gain head and neck control first, then trunk control, then legs and feet.
Precisely. And if you think about a very premature infant, that incomplete myelinization, that CNS immaturity,
How does that show up immediately, like in the NICU?
it manifests in problems with basic autonomic control. So yes, motor delays, but even more urgently, things like apnea pauses in breathing and real difficulty coordinating sucking, swallowing, and breathing all at once. That makes feeding incredibly challenging.
Okay, so understanding that anatomical and physiological foundation is key. Now, how do we assess for problems? Your sources really stress starting gentle, right? Least invasive to most invasive.
Always. Especially with kids. You might need toys, involve the parents, use play to get their cooperation. It's essential.
And the health history, looking for things like prematurity, birth issues.
Right. But the physical exam is where you get that real-time data. And the number one thing, the earliest sign that something's wrong neurologically, is a change in their level of consciousness. LOC.
Okay, LOC.
Yeah.
We need to be super clear on the progression here. It's a spectrum.
It is. You start with full consciousness alert, oriented, behaving appropriately for their age. Then comes confusion. They're awake, but maybe disoriented, not responding quite right.
Then obtunded.
Yeah, obtunded means they'll drift off to sleep unless you're actively stimulating them. Then stupor, you need really strong, often painful stimulation to get any response at all. And the most critical stage is coma. Absolutely no response, even to painful stimuli. That's a neurological emergency.
And to track this objectively, we use the Pediatric Glasgow Coma Scale, the GCS.
Right. It's standardized, looks at 3 things. Eye-opening verbal response or sounds for infants and motor response.
Simple scale, but powerful implication. The lower that GCS score.
The less responsive the child and generally the poorer the prognosis. It's a vital tool.
Okay, so LOC and GCS are key. Let's link that assessment directly to the big, scary complication. Increased intracranial pressure, or ICP.
Yes. This is where assessment has to be meticulous and fast, because rising ICP can cause irreversible brain damage very quickly.
And for infants, there's that unique measurement, right? Head circumference.
Yeah.
Standard till they're about 3.
Exactly, you track it over time. If the head isn't growing enough, you worry about microcephaly. But if it's increasing too rapidly, crossing percentile lines, that's a huge red flag for hydrocephalus, which is often driven by high ICP.
We need to distinguish between the early signs of rising ICP and the late, really dangerous signs. What are the early clues?
They can be subtle, easily missed. Things like headache if the child's old enough to tell you vomiting, maybe some dizziness, blurred vision, sometimes just increased irritability.
Kind of nonspecific sometimes.
Very, which is why you need a high index of suspicion. But the late signs, they are unmistakable signs of brain herniation starting.
Okay, what are those late critical signs?
You'll see a significant drop in the level of consciousness, decreased motor and sensory responses. You might see changes in vital signs, the bradycardia, so a slow heart rate, irregular breathing patterns, maybe hypertension, but that can be tricky to measure accurately in acutely ill kids.
And posturing. That's a really ominous late sign.
Absolutely. Abnormal posturing indicates severe brain injury, and the type of posturing can even suggest where the damage is.
Your sources mention figures showing the two main types, decorticate and decerebrate. Can you describe those for us? What are we seeing?
Okay, so decorticate posturing, think flexor. The arms are pulled tightly in towards the core of the body. Elbows, wrists, fingers, all flexed. Fists might be clenched. Legs are usually extended and internally rotated. This suggests damage above the brainstem in the cerebral cortex pathways.
And decerebrate.
Decerebrate is extensor posturing, and it's generally considered more severe. Here, the arms are stiffly extended away from the body, pronated, palms facing down or back, wrists flexed. Legs are also extended. This points to damage at the level of the brainstem, which controls vital functions. It's a really critical sign. Immediate intervention needed.
Wow, okay, so beyond just looking and measuring, what about diagnostic tests? Lumbar puncture comes up often.
Yeah, the LT, or spinal tap. It's essential for analyzing the cerebrospinal fluid, the CSF. You're looking for signs of infection bacteria, white blood cells, or blood, which indicates hemorrhage.
And a couple of key nursing points with LPs.
Positioning is critical for safety and success. You need the child curled up, usually side-lying, to open up those vertebral spaces, like a C shape. And afterwards, getting those results reported quickly, especially if infection is suspected, is vital. It's actually a national patient safety goal. And of course, you have imaging CT scans, MRIs for detailed structure, EEGs to look for seizure activity.
Okay, let's shift gears to what we do, nursing interventions. Key diagnoses seem to be things like decreased intracranial adaptive capacity, risk for injury, risk for infection.
Makes sense.
So for managing that high ICP, what are the core interventions? What's the rationale?
First, positioning. Elevate the head of the bed, usually 15 to 30 degrees, and keep the head midline neutral. This helps promote venous drainage from the head, reducing pressure. Simple, but effective. Second, minimize stimuli. Keep the room quiet, lights dim, cluster your care activities. Because pain, noise, agitation, they can all spike ICP.
Right, and for seizure management, the big thing is safety, right? Seizure precautions.
Absolutely. Padding the bed rails, having oxygen and suction equipment right there, ready to go. But just as important is knowing what not to do during an active seizure.
Okay, what are the absolute don'ts?
Number 1, never ever try to force anything into the child's mouth like a tongue blade. Huge risk of injury to teeth, gums, or even obstructing the airway. And number 2, don't restrain the child's movements. You could cause fractures or other injuries. Your job is to protect them from injury, ease them to the floor if standing, turn them on their side if possible, clear the area around them.
Got it. What about managing devices like an external ventricular drain, an EVD, for hydrocephalus? That seems really high risk.
It requires extreme vigilance. You're constantly checking the connections need to be sterile and secure to prevent infection. Monitoring the CSF drainage, the amount, the color, the clarity. It should be clear, maybe slightly yellow, but not cloudy or bloody. And the height of the drip chamber is critical. It has to be exactly level as prescribed relative to the child's head, usually the tragus of the ear or external auditory meatus.
Why is the height so critical?
Because if the drain is too low, or if the system is open and the child suddenly sits up, gravity will cause CSF to drain out way too quickly. That can lead to headache, nausea, vomiting, even ventricular collapse, or a subdural hematoma from the brain pulling away. It's incredibly dangerous. Clamp the drain before moving the patient.
Okay, really important details. Let's talk about specific types of disorders now, starting with seizures. Epilepsy is the term for recurrent unprovoked seizures, and there's a classification system.
Yes, the ILAE classification. It's based on where the seizure begins. So focal seizures start in one area, Generalized seizures involve both hemispheres from the start, and then there's unknown onset.
And the type people often picture is the tonic-clonic, right? Grand mal's the old term.
Hey, that's the classic one. Often starts with an aura, a warning sign. Then the tonic phase. Body stiffens, muscles contract. Followed by the clonic phase. Rhythmic jerking movements. And afterwards, the perstictal state. Confusion, lethargy, deep sleep, sometimes for hours.
What about febrile seizures? Super common, right?
Most common type in young children, usually under 5. Linked to a rapid spike in fever, typically over 39 Celsius or 102 Fahrenheit. They're scary for parents to witness, for sure. But the key thing for you to know is they are generally considered benign.
Meaning no long-term treatment, usually.
Correct. For simple febrile seizures, the consensus, like from the AAP, is that the risks of daily anticonvulsant medication outweigh the benefits. Treatment is usually supportive during the fever.
Okay. Shifting to structural defects, prevention is a big theme here, especially for neural tube defects and TDs.
Absolutely. Folic acid. The recommendation for adequate folic acid intake before conception and during early pregnancy is probably one of the most impactful public health measures for preventing NTDs like spina bifida.
And if a baby does have hydrocephalus, maybe from an NTD or another cause, what are those key assessment findings in an infant?
You're looking for that head circumference growing way too fast, crossing percentiles on the growth chart. The fontanels, the soft spots will feel full, tense, maybe bulging, and you might see that classic sign called setting sun eyes or sunsetting.
Can you describe that?
Yeah, it's where the pressure is so high it actually pushes the eyeballs downward slightly, so the sclera, the white part, is visible above the iris. Looks like the sun setting on the horizon.
Wow. Okay, infectious disorders next. Bacterial meningitis. Sounds like a true emergency.
It absolutely is. Rapid diagnosis and treatment are critical because deterioration can happen incredibly fast, sometimes in less than 24 hours.
What are the telltale signs? Different in infants versus older kids.
Somewhat. In infants, besides fever and poor feeding, you might see that odd posture called opisthotonos, where they arch their head and neck back rigidly. It's an attempt to relieve the pressure on the meninges. In older children, you look for classic signs of meningeal irritation, severe headache, stiff neck, neutral rigidity, and photophobia. And then the specific signs, Kernig's and Brudzinski's.
Okay, let's describe those tests vocally. Kernig's sign.
You have the child lying flat on their back. You flex their hip and knee to 90 degrees, then try to straighten the knee. If it causes significant pain or resistance in the hamstring, that's a positive Kernig's sign. Suggests meningeal irritation.
And Brudzinski's sign.
Again, child is supine. You gently lift their head, flexing the neck towards the chest. If their hips and knees automatically flex involuntarily in response, that's a positive Brudzinski's sign. Same implication, meningeal irritation.
Got it. We should also quickly touch on Ray's syndrome. Less common now, but important history.
Very important. Ray syndrome involves acute brain swelling, encephalopathy, and liver failure. The key link is using aspirin or other salicylates during or after a viral illness, like chickenpox or the flu, in kids and teens. That's why we avoid aspirin for fever or pain in children now. Use acetaminophen or ibuprofen instead.
A crucial point. Okay, finally, let's address trauma. Sadly, it's the leading cause of death and disability in childhood.
It is, and head injuries are a huge part of that. Concussions characterized by confusion, maybe some amnesia are common, but then you have more severe injuries like hematomas.
Subdural versus epidural.
Right. But perhaps the most tragic is non-accidental head trauma, shaken baby syndrome, or SBS.
Because infants are just so vulnerable to that shaking mechanism.
Yeah, exactly. That big, heavy head, weak neck muscles. The forces generated inside the skull are immense. It causes shearing of blood vessels, bruising of the brain.
And the scary thing is, there might be no outward signs of injury.
Often not. The damage is internal. You look for intracranial bleeding, and very characteristically, retinal hemorrhages bleeding in the back of the eye. Seeing those is a major red flag. And as a nurse, if you suspect non-accidental trauma, reporting is absolutely mandatory immediately.
Okay, if a child does have a mild or moderate closed head injury, and they're stable enough to go home, what are the critical discharge instructions for parents? Your source outlines these clearly.
Yes, very specific guidelines. First, the parent or caregiver must stay with the child for at least the first 24 hours, no exceptions. Second, they need to wake the child up every 2 to 4 hours.
Why wake them?
To check their level of consciousness. Do they recognize the parent? Do they respond appropriately? Can they move their arms and legs normally? You need to ensure they haven't deteriorated while sleeping. And third, the parents need a list of specific signs that mean come back to the ER immediately.
What's on that list?
Things like a headache that gets worse or doesn't go away with medicine, vomiting more than twice, unequal pupil size, any seizure activity, difficulty waking up or increased confusion, slurred speech, any loss of coordination or weakness.
Okay, crucial info for parents. And linking all this back to prevention held, healthy people 2030 goals.
It always comes back to prevention where possible. Helmets, bikes, scooters, skateboarding, proper car seat use, every single time. Water safety is huge too, preventing near drowning, which causes hypoxic brain injury, pool fences, constant supervision around any water.
So wrapping this all up, what's the big takeaway for someone learning about pediatric neuro?
I think it's the precision required. Because of those unique anatomical and physiological vulnerabilities in kids, small changes can mean big problems, and early deficits can have lifelong consequences. Your assessment has to be sharp, your interventions timely and correct, and it has to be holistic, looking at the child's development, not just the immediate problem.
And your source material brings up a really powerful point near the end, the words of wisdom about listening to parents.
Yes. It's so important. These neurologic conditions are often chronic, incredibly demanding for families. Parents become the absolute experts on their child's day-to-day status, their subtle changes, their baseline. As nurses, we have to respect that expertise, partner with them, and really listen to their concerns. How are we supporting their needs as they navigate this incredibly difficult journey?
That's a really profound thought to end on. It really reframes the partnership aspect of care.
It does. It's essential. Well, thank you for digging into this complex topic with me.
Absolutely. And thank you, our listener, for joining us on this deep dive. Huge thanks, as always, to the Last Minute Lecture team for making this possible. We'll catch you on the next one.